Healthy eating for people with chronic kidney disease (CKD). A detailed, evidence-based guide introduction. Why diet matters in CKD. Chronic kidney disease (CKD) means the kidneys cannot filter blood as well as they should. That causes buildup of waste products, fluid, and certain electrolytes, sodium, potassium, phosphorus, and can affect blood pressure, bone health, and overall well-being. Nutrition is one of the most powerful, cost-effective tools to slow progression of CKD, reduce symptoms, swelling, breathlessness, fatigue, and lower risks of cardiovascular disease. Major nephrology guidelines now emphasize individualized nutrition care provided by renal dietitians. Overall goals of nutrition in CKD. 1. Protect remaining kidney function by avoiding excess dietary stressors, e.g., very high protein and excess sodium. 2. Maintain good nutritional status. Avoid unintentional weight loss or protein energy wasting. Adequate calories are essential. 3. Control blood pressure, blood sugar, and cardiovascular risk through salt reduction, healthy fats, appropriate kcal intake. 4. Prevent dangerous electrolyte imbalances, especially potassium and phosphorus, that can cause heart rhythm problems or bone disease. Key nutrients and practical guidance. Protein. How much and what kind? Why it matters. Protein breakdown creates nitrogenous waste, urea, creatinine, that kidneys must clear. Too much protein can increase kidney workload. Too little causes muscle wasting and malnutrition. Guideline summary. For many adults with CKD stages G3, G5, not on dialysis, a moderate protein intake around 0.6 to 0.8 g/kg body weight/day is commonly recommended, with adjustments made based on stage, symptoms, and presence of inflammation or malnutrition. Digo and Doki emphasize individualized targets and dietitian supervision. Protein quality. Emphasize high biologic value protein, eggs, poultry, fish, dairy, and moderate amounts, when intake is restricted, but growing evidence supports plant-dominant, low-protein approaches, plateau, for earlier CKD as protective and cardiometabolic beneficial. Plant proteins, beans, lentils, tofu, may be associated with lower acid load and fewer harmful metabolites. However, potassium and phosphorus content of plant foods must be managed. Practical tips. Calculate target grams. 0.8 g/kg for a 70 kg adult is almost equal to 56 g protein/day. Spread protein across meals. If advised to restrict protein, include one good protein source at one meal and modest portions elsewhere. Work with a renal dietitian to prevent undernutrition. Sodium, salt. Why it matters. Sodium increases fluid retention and blood pressure, worsening edema and cardiovascular strain. Sodium reduction is one of the most effective dietary changes to manage blood pressure and fluid. Target. Many guidelines suggest aiming for 2 g sodium/day is almost equal to 5 g salt, or individualized targets to control BP and edema. Reducing processed foods is key. Practical tips. Avoid processed, ready meals, canned soups/sauces, salty snacks, cured meats, and many restaurant foods. Use herbs, lemon, garlic, and vinegar instead of salt for flavor. Check labels for sodium and phosphate additives. Potassium. Why it matters. When kidneys fail to remove potassium, blood levels can rise. Hyperkalemia. Approach. Monitor serum potassium. If elevated, reduce or modify high potassium foods. Use cooking techniques, leaching, double cooking, to lower potassium in vegetables. Choose lower potassium fruit/veg. Refer to dietitian guidance. Practical tips. Soak and boil certain vegetables and discard cooking water to lower potassium. Favor apples, berries, grapes, cauliflower, cucumber over bananas, oranges, potatoes, tomatoes when hyperkalemia is present. Avoid sudden introduction of high potassium salt substitutes. Many contain potassium chloride. Phosphorus. Why it matters. High phosphorus in CKD leads to bone disease, renal osteodystrophy, and vascular calcification. Processed foods and phosphate additives are big contributors. Approach: limit foods high in inorganic phosphate additives and titrate dairy, nuts, cola drinks, and processed meats. Prefer phosphorus from whole foods, plant organic phosphorus, which is less bioavailable. Practical tips: read labels. Phosphate, phosphoric acid, calcium phosphate. Additives are highly absorbable. Limit cola drinks and processed cheeses. Choose whole grains and plant sources when possible. Plant phosphorus binds to fiber and is less absorbed. Fluids and weight control. Fluid needs depend on urine output, edema, and dialysis status. Many non-dialysis CKD patients do not need extreme fluid restriction, but those with noticeable swelling or low urine output may need limits. Monitor daily weights and swelling. Calories and weight. Maintain enough calories to prevent muscle breakdown is almost equal to 25-35 kcal/kg/day, tailored. Weight loss should be intentional and supervised. Rapid or unplanned loss requires evaluation. 1. Plant-dominant low-protein diet, plateau. Evidence shows plateau can slow CKD progression in non-dialysis patients, improve metabolic risk, reduce acid load, and may delay dialysis. It focuses on more plant foods and lower total protein, but adequate calories, often supplemented when very low protein is used. Recent reviews support plateau as an attractive, sustainable strategy. 2. Mediterranean/DASH patterns. Diets rich in vegetables, fruits, adjusted for potassium, legumes, whole grains, olive oil, and fish are associated with cardiovascular benefits and often slower CKD progression if tailored properly. DASH may be high in potassium and requires adaptation for CKD. Foods to emphasize: general, fresh vegetables and fruits. Choose lower potassium options if needed. Whole grains in moderation. Watch phosphorus and potassium. Healthy fats, olive oil, fatty fish for cardiovascular protection. Moderate portions of lean poultry, fish, eggs, plant proteins, tofu, legumes, adjusted for potassium/phosphorus. Foods to limit or avoid: processed and convenience foods, high in sodium and phosphate additives. Dark colas and phosphate-containing beverages. High potassium fruits. If hyperkalemia present: bananas, dates, dried fruits, oranges. Excessive dairy and nuts: phosphorus, when serum phosphate is high. Cooking and preparation tricks to lower potassium/phosphorus: leaching. Double boil peel and cube vegetables. Boil in a large pot for several minutes, discard water, and then cook in fresh water. This reduces potassium content. Useful for potatoes, sweet potatoes, carrots. Avoid phosphate additives. Remove processed meats and packaged sauces. Choose fresh foods. Sample one-day meal plan. Example: adjust per individual labs and dietitian advice. Note: this is illustrative. Protein targets must be calculated individually. Breakfast: porridge oats, with water or low-phosphate milk alternative, topped with blueberries and a small sprinkle of seeds. 1 boiled egg, if protein within target. Mid-morning snack: apple or grapes, lower potassium. Lunch: a grilled chicken breast, small portion 60-80 g, or baked white fish, mixed salad with cucumber, lettuce, peppers leached if needed, olive oil plus lemon dressing, white rice or small portion of whole grain. Afternoon snack: rice cakes with low-salt hummus portioned. Dinner: stir-fried tofu and mixed vegetables. Use low-potassium veg if needed, with herbs and garlic, mashed cauliflower or small potato leached. Fluids and extras: limit tea/coffee if advised. Avoid cola drinks and sports drinks high in phosphate. Adapt choices for potassium/phosphate/protein intake using lab results and RD guidance. Supplements, vitamins and herbs. Caution: many over-the-counter supplements contain potassium, phosphorus, or herbal compounds that are harmful in CKD. Do not take supplements without discussing with a nephrologist or renal dietitian. Vitamin D, phosphate binders, or other medications may be prescribed based on blood tests. Monitoring and when to refer to a renal dietitian. Regular monitoring of serum creatinine/eGFR, potassium, phosphate, calcium, albumin, and weight is essential. Adjust diet based on labs, symptoms, and comorbidities. Diabetes, heart disease. Digo and Doki recommend renal dietitians to tailor nutrition therapy. If you have elevated potassium, high phosphate, unintentional weight loss, or are stage G3, G5, request medical nutrition therapy (MNT). Special considerations: diabetes plus CKD. Control carbohydrate quality and quantity. Avoid high glycemic processed carbs. Balance blood sugar control with kidney-friendly food choices. Work with both nephrologist and diabetes educator/dietitian. Older adults/frailty. Higher risk of malnutrition. Protein targets may need to be less restrictive to preserve muscle. Individualized assessment is critical. Cultural and budgetary adaptation. Plateau and Mediterranean patterns can be adapted to regional staples, legumes, local vegetables, small fish. Emphasis on fresh food, limiting processed items, and modest animal protein portions. Evidence highlights and newsworthy points you can use in a video. Things people don't always know. 1. Plant-dominant low-protein diets, plateau, are not just vegetarian diets. They combine lower total protein with mainly plant protein, and may delay dialysis and improve metabolic health in non-dialysis CKD. This is a current active research area with growing support. 2. Phosphate additives are a hidden hazard. Processed foods often contain highly absorbable inorganic phosphates that raise serum phosphorus more than natural foods do. Reading labels can make a big difference. 3. Not all potassium-rich foods are forbidden. Many fruits and vegetables are beneficial. The decision to limit is lab-driven. Cooking techniques, leaching, can reduce potassium substantially. 4. Sodium reduction remains the single most effective self-care step to control blood pressure and fluid in CKD. Many patients underestimate sodium in healthy processed foods. Silent. Five. Individualization is mandatory. Modern guidelines, Digo Doki, stress individualized targets and the importance of renal dietitians rather than one-size-fits-all rules. Practical checklist for patients. Short. Get baseline labs. eGFR, K+, PO4, Ca, albumin, weight. Ask for a referral to a renal dietitian. Reduce processed foods and read labels for sodium/phosphate additives. Calculate your protein target with a clinician and spread it across meals. Monitor weight daily if fluid issues. Avoid potassium salt substitutes unless cleared by your team. References and resources, useful websites to cite/share. Digo 2024 CKD Clinical Practice Guideline, Full Guideline and Executive Summary. Adoki Clinical Practice Guideline for Nutrition in CKD, 2020 Update. A National Kidney Foundation, Nutrition and CKD pages, NKF Nutrition Hub, Phosphorus Guidance. ANIDDK, Healthy Eating for Adults with CKD. A recent PubMed reviews on plant-dominant, low-protein diets and plant-based diets in CKD. If you want, I can next turn this into a YouTube video script with short scene breakdowns and on-screen text, or produce an Arabic translation for voiceover subtitles, or create social carousel slides. 6.